Thank you, Team IDCM, especially Akash sir, for inviting me. And the disclaimer is this session is sponsored by Sanofi, but I shall try to present those data which had been scrutinized by evidence-based medicine only. So as we are going to discuss about our approach to diabetes care with some generation 2 basal insulin, we'll talk about Glargine 300 across patient population. So we know from our medical school days, we were being taught about we should not use this principle, one drug for every disease or one dose is not fit for all. But with some pinch of salt, whether we can say Glargine U300 can be used in a heterogeneous population, different subgroups of our type 2 diabetic patient, that what are the evidences saying, we'll try to understand. So first of all, we need to acknowledge we are sitting on top of diabetes epicenter of the world, and unfortunately but true, only 20% of our type 2 diabetes patients are achieving their glycemic control. Most importantly, the data suggest from this landmark study that less than 1 in 4 Indians, who are suffering from type 2 diabetes, are taking insulin. I think many of us will be sad to know this fact, because insulin is that glucose lowering agent among all those glucose lowering agents we have, which has the most predictable response, highest efficacy. It can reduce HbA1c starting from 1% to 10%. And when we are talking about insulin, we are very much confident about its safety, apart from some issues like hypoglycemia or weight gain. But in background, we have 100 years of experience with insulin. Not only that, when we talk about insulin in Indian context, we are talking those populations when they being diagnosed with type 2 diabetes, already more than 60% of their beta cell is not working appropriately. On top of that, with days running, this beta cell function goes gradually declining. So in that setting, this is something which is a very sad story. And when we talk about insulin initiation, the mean HbA1c which was found to be 9.2%. So we generally follow a step-up approach. We start with OAD monotherapy, then we need to wait for maybe 3 years in this particular study that had been shown. Then we start another OAD. So there is a lag in intensification, and that is very crucial because we are losing the early days. And if we can control sugar early, if we hit hard early, that will give a good glycemic memory, and that is associated with a legacy effect. But unfortunately, we miss the chance and we achieve a poor glycemic control, and generally the data suggest we need to wait for more than 7 years before intensification starting insulin. So that is a very sad story. So this was one study done by our team where we had initiated insulin very early with diagnosis. Generally this study, the mean HbA1c was more than 13%, and we give insulin for 3 months. There is a drop of HbA1c below 6.5% within 3 months, and then we continue only one OAD. And it was found that this group had long-term benefits with insulin, early initiation of insulin, which translate the good glycemic memory. The thing is that when we talk about insulin, especially basal insulin, previously what happened in UKPDS, what we had shown, even in the intensive control arm, even in the arm who were receiving insulin or the sulfonylureas, the general natural history of diabetes was progressive. After 8 years, 9 years, all the arms, there were increase in HbA1c value. Again, if we go to the ADOPT trial, then also the HbA1c was higher compared to the baseline with 8 years, 10 years after the initiation of the trial. But if we go through the data from origin trial, where the basal insulin was initiated in very early stage of disease, and the mean HbA1c was around 6.5%, then that trial only had shown after 7 years also, the mean HbA1c, there is one drop, it was around 6.4%. So I think with initiation of this type of basal insulin, which can give us some boost to actually achieve the normal fasting plasma glucose value, and that normal fasting plasma glucose value along with minimizing those diurnal variation, targeting the glycemic variability, we can reach that good glycemic memory goal, which can provide a long-term achievement. Obviously, we have other agents nowadays which was not there during the ADOPT trial or UKPDS, like GLP-1RA or SGLT2 inhibitors, which have also this effect on pleiotropic effects on beta cells. So now when we talk about insulin, we know the advantages of insulin. At the same time, we had a fear of initiation of insulin. The main two fear is obviously the hypoglycemia, and then is the weight gain. If we can minimize those two things, those two safety concerns, like if we can have some less hypoglycemia, less weight gain, with equitable reduction in HbA1c, so that nothing like that. And I think some pharmaceutical modification conducted, and we got this glargine U300, which is nothing but the same glargine which we had, just that is in some compact mode. The cross-sectional area of that injection become reduced, and as it was reduced, the release was reduced, and as the release was reduced, the T-hub was increased, and it gives a flat peak. There was no peak, that was a flat pharmacokinetic pharmacodynamic profile. So we got something which has a stable prolonged action with flexible dosing, plus minus 3 hours, with less weight gain, safer titration maintenance time, less chance of hypoglycemia, less glycemic variability, with similar type of glycemic control. So when we talk about our glycemic triad, initially the metabolic control, we were talking about fasting plasma glucose control, postprandial glucose control, and HbA1c control. Now we all know we need to target the glycemic sixer. There is 3 additional outcome we need to check. 3 endpoints, more 3 endpoints apart from those fasting PP and HbA1c. And that is the glycemic variability. Second is the nocturnal hypoglycemia. And third is the overall hypoglycemia. And in this whole galaxy of studies that had been conducted with glargine U300, starting from PKPD to different RCTs, and even some real-world evidence studies that had shown the glargine EU300 has similar efficacy with IDEC, that is Degludec, and the glargine EU100, but sometimes it is better in terms of reduction in the glycemic variability and reduction in the nocturnal hypoglycemia, especially when we are intensifying the therapy in the early initiations. Again, we had done one real-world evidence study which had shown the benefit of glargine EU300. This was very early days. Now we had also compared EU300 with EU100, and that in the population where we are getting OAD failure. So that had also shown the efficacy and safety of EU300. Now coming to different population with CKD and elderly population. When we talk about elderly population, they are clinical trial orphan, because most of the clinical trials, they generally not include the elderly population. But there are a good number of studies conducted with glargine EU300 where it had been shown the glargine EU300 arm carries less chance of hypoglycemia. Even in the addition trial, it had been shown they have equal efficacy with glargine EU100, but 18% relative risk reduction in case of confirmed hypoglycemia. Across the other studies from ETOS to BRIGHT to DELIVER, there is similar type of results. The most importantly, the efficacy is same, safety is more. Now coming to the renal impairment patients, those studies again in a good number of population in the addition trial, DELIVER studies, there they had shown there is less hypoglycemia in the glargine EU300 arm. Even in the BRIGHT study, they had shown the similar type of HbA1c reduction compared to the Degludec without increasing the risk of hypoglycemia. And ETOS also the very low risk of hypoglycemia. If we want to dissect the data from the BRIGHT study, the glargine EU300, they had shown the greater HbA1c reduction with comparable risk of hypoglycemia in the patients who has impaired renal function compared to the Degludec 100. And when we talk about the across different EGFR group, most importantly in the moderate to severe impaired renal function group, there was HbA1c reduction of 0.7% in the glargine EU300 arm. So overall, we know that the glargine EU300 or any insulin will reduce the HbA1c. But what happened with safety in this population where renal impairment is there? The safety concerns like hypoglycemia was very minimal in the glargine EU300 arm. And even if we get some data from the real world evidence studies, observational studies that had shown the glargine EU300 produce a robust glycemic improvement along with a favorable safety profile in those who has less EGFR. And when we talk about DELIVER study, which includes very high risk patient, and that is a real world study that had shown who the patients were actually switch over from glargine EU100 or Tetemid. In both case scenario, that when they were shifted to the glargine EU300 arm, there were similar HbA1c reduction. At the same time, the hypoglycemia events were less when they were shifted to the glargine EU300 compared to the two first generation basal insulin. So when we talk about ETOS study where elderly populations were included, overall incidence of hypoglycemia was low in 6 and 12 months of those studies. Most importantly, the deliver 3, which was again collecting to those patients who were elderly, and there are different separate subgroups were being analyzed. They had shown the glargine U300 has lesser hypoglycemia compared to the other basal insulin. And when we talk about deliver 3, the most important take-home message should be the hypoglycemia, even in real-world setting, they had shown much lesser compared to other basal insulin. Why the real-world evidence studies are important? Because they has the highest external validity. We talked a lot about in clinical trials. Clinical trial has robust internal validity, but very less external validity. But when we dissect data through the magnifying glass of real-world observational studies, that they are carrying more external validity. Now, if we go by this senior study, there it was found comparable hypoglycemic event, though there is a trend towards glargine 300 more safe compared to glargine 100, but in the subgroup when the age is more than 75, there is clear-cut benefit in favor of glargine U300. And one group where documented hypoglycemia were noted, documented less than 54 milligram per dl hypoglycemia were noted, there was 92% relative risk reduction in favor of glargine U300, and that was statistically significant. Now coming to another group of population, type 1 diabetics. When we talk about type 1 diabetes, they are the very good experimental model where we found the pharmacokinetic, pharmacodynamic parameters without much confounders. So here, comparing to Digludac, there is 22% greater insulin peak in the Digludac arm compared to the glargine U300, and 23% lesser glycemic variability in favor of glargine U300 arm. Now, another one-care study, that was again a real-world evidence study, that also showing benefits in terms of time in range and time above range favoring glargine U300.
Dr. Sambo.
Okay. So, when we talk about again nocturnal hypoglycemia, there were certain benefits in terms of in favor of glargine U300. We talk about Ramadan, and when we dissect the data from Orion study, that had also shown or support the use of glargine U300. In the glargine U300 arm, there was more compliance or adherence we need to admit. Now, pregnancy. The thing is that glargine U300 is nothing but a concentrated form of glargine U100. So, when we talk about glargine U100, we know in certain situation now glargine U100 is safe in pregnancy, though this statement need to be considered with some pinch of salt, but there were studies now that available from different part of globe which suggest the safety of glargine U300 in pregnancy too. And we had also conducted one study which includes almost 64 subjects, and that compared glargine U100 with detamid, and U100 arm there was a benefit in terms of lesser glycemic variability, and also the fetal outcome was not different in two arms. When finally we talk about device, because when insulin is being we are talking about insulin, the injection is something that is very crucial, and if we have a very good device, that improves the efficiency of overall insulin therapy. And that is why this glargine U300 cartridge, they are something better in terms of other pain that are available. And when we talk about the wall of evidence with Glargine 300 studies, we already had discussed there are different pharmacokinetic, pharmacodynamic studies, real world evidence studies, and also some robust clinical trials that we had. On top of that, starting from 2002, we are using Glargine 100 that had already a robust evidences. Now this wall of evidence become Chinese wall of evidence, we may say. So evidence of Glargine 300, I think time is short, we need to finish it. This is the take home message. We can use Glargine 300 across the patient profile. It could be some patients who has busy and erratic lifestyle, because there is a plus minus 3 hours of injection time at risk of hypoglycemia. Clearly the evidence is saying there is less chance of hypoglycemia, less glycemic variability. We can use it in hospital too, pregnant ladies, elderly population, CKD and type 1 diabetics. So thank you for giving me this opportunity.
Thank you so much, Dr. Sambo.